Depression is feeling like you've lost something, but having no clue when or where you last had it. Good day, everyone. My name is Dr. Amaladoss. It gives me great pleasure to be here all with you and to be invited to your conference to talk about what I see as a very relevant and an important topic for the treatment of patients who suffer with this condition. My name is Dr. Alfred Amaladoss. I'm an assistant clinical professor at the Department of Psychiatry, and I also have cross-appointmentship at the Department of Anesthesiology. I'm also the medical director of the Mind Revive Clinic. Today, I'd like to talk to you on the approach to the early detection and treatment of a condition that we're all so familiar with. It's certainly a Herculean task to talk about such a big topic, and I really would like to anchor it on some few key areas. Before I start, I'd like to share with you some of my disclosures and the involvements with different companies and agencies that I've worked with. I believe that partnerships multilaterally can provide patients with the best hope and care. And so with this understanding, I've involved myself with numerous organizations. The overarching aspects of this topic will be hinged on three major areas. We'll discuss the importance of early identification and treatment of major depressive disorder. We'll review mechanistic approaches to treat this condition and talk about some of the other management approaches that you can do in your practice to target such a huge and prevalent condition. To mitigate any potential bias, I've reviewed the clinical guidelines, literature review, and other relevant evidence-based articles to make this topic non-biased and wholesome for your review and for your further care of your patients that you serve. It comes to no surprise that depression is a common and leading condition. This is very noted by all of us for the clients that we treat every single day, and also quite relevant when we start seeing the stresses we live in the current climate and situation with the current COVID-19 situation. Huge amounts of stress are being placed on people. And so the sequelae of stress can also lead to this very prevalent condition, what we call as depression. Globally, we see striking numbers of 322 million who've experienced depression. And as we know, it's the largest contributor to disability worldwide. On home soil, home territory, we see that large amounts of people, up to 1.5 million, are affected by this condition. And 25% of Canadians have reported a lifetime experience of depression in some capacity. As our understanding of depression has grown, so must the expectation of treatments that we provide to clients. We've done such a great job in determining numerous treatments for depression, but we're still not there in terms of fully bringing it to sort of the new target goalpost, which is full remission. And we start seeing that with clients that we treat, and even from studies, that there's a huge proportion of people who have what we call a residual symptoms of depression, symptoms that tend to sort of linger throughout. We see it in key areas of sleep, energy, as well as cognition. In this one study by Conradi, who's assessed close to 260 patients, assessed over a period of 3 years, it was important to see these striking numbers of close to 85 to 90% were having residual symptoms during a major depressive episode. And after a non-major depressive episode, close to 40% of people were still having it. The importance of treating depression is to be noted. We see very good clinical studies talking about the effect of a lot of these antidepressants would have on depression outcomes. But we start looking at long-term outcomes for depression, it's disappointing. And that's either because diagnoses are often missed, underdiagnosed, there is ineffectual treatment paradigms, treatment is not optimal as we want it to be, and so for residual symptoms of depression still persist. The importance of identifying comorbidity should certainly be stressed, because one of the factors of driving major depression is the fact of comorbidities, anxiety conditions, substance use disorders. So it is very important to stress the point that failure to treat to full remission can sometimes lead to poor outcomes of major depression. Now, the consequence of not treating to full remission is the fact that patients who have residual symptoms have increased risk of relapse. They become very hard to treat. They become what we call our treatment resistant. And that is not just a medical term. It also speaks to very much their functional impairments in both work, home, and personal life. Far more so is the risk of mortality. And we talk of the high increasing risk of suicide in such clients. And when we think of depression going beyond just the paradigm of neurotransmission, we start seeing that it is a condition very much involving inflammation for a substantial group of patients. And it comes to no surprise that with that type of implication, other medical disorders can certainly become more aggravated. The approach to patients with major depressive disorder, specifically those with residual depression, would fall under the typical heuristic approach to do a thorough assessment. And this would always include the three pillars, what we all are very familiar and what we all do. It is a thorough history talking about the onset of symptoms, combing through whether patients are fully gone into remission, looking for the comorbidities, looking at the quality of these residual symptoms. How did they begin? Were they always there? Did they evolve? Were they iatrogenic? Are they medication induced, etc.? These can be some few key things to consider when you're evaluating your clients. Your examination will also be very relevant when you're trying to assess the quality of their depressive symptoms, or look for any other factors such as sedation, which can come from medications as well. And always, looking for other investigations, relevant investigations, things that can also contribute towards their depression: undetected B12, thyroid levels, iron, etc. As part of the history, I thought of also adding in some other key things that I like to consider when I'm reviewing major depression in terms of outcome-based treatments, outcome-based measures. Looking at risk factor always, when we start thinking residual symptoms as high risk, really looking at risk more than a cross-sectional approach, as opposed to what we should be seeing is more of a longitudinal assessment of risk. You want to be looking at past treatments, fully determining if they've had an adequate trial, determined by dosing, duration, responsiveness. And I think the role of genetics certainly plays a promising role when you start asking patients of what they've been on, what they've tried, especially when you're thinking of what to add next to get those residual symptoms better. And as always, looking for important comorbidity and evaluating risk. This slide talks about the other major phase of assessment of depression as well as residual symptoms. Sort of these key areas that we all tend to do, but it's a quick visual reminder of what should this encompass. A good mental status examination, physical examination, and what we call our measure-based tools. What you track is what you measure is what you know. And here are some few scales that we might be doing in clinical practice. And if not, to please certainly consider them. One is the PHQ-9, which is a patient-centered questionnaire that can help evaluate symptoms and look at frequency. Similar, the other one is GAD-7, the Generalized Anxiety Disorder Scale. And again, it's patient-derived. Patients assess these scales and they mark off the frequency. Frequency can tell us a lot about where symptoms are at in terms of their baseline, and when you see treatments, to see the scores improve or worsen or not get better are all very relevant things to consider. And always with every measure-based scale that includes symptoms, it's always good to couple this with functional scales. And just to list some of them, the Hudas and the Sheehan scale. When we move towards the other major approach of treating depression, specifically residual symptoms to remission, it's important to keep the three big principles, the biopsychosocial approach, which is sort of a treatment approach that's been long established as a key area to get patient wellness thoroughly under control. And this includes the use of biological reviews and treatments, psychological reviews and treatments, and social interventions and behavioral. As for the purpose of time and the complexity of this condition, I've chosen to approach this primarily from a biological point of view. Certainly, I cannot underscore the importance of nutrition, hydration, exercise, stability of sleep, and that would be certainly for a separate discussion to talk more about. But as for medications, if you're dealing with residual symptoms and the determination is to get your clients fully better, you really want to talk about, how do you go about approaching it? Would you want to add a medication, or we call it add-on or augment, or would you want to switch? And based upon guidelines, here are some few guiding principles to help you evaluate that. Choosing another antidepressant may be considered if it's your first antidepressant trial, the medication is poorly tolerated, you really are not getting much movement in the response, defined as less than 25%. There's more time to wait for response. So that might be something to consider. When we talk of severity, so when you have to get a patient better, you might have to pull down a medication and start something. So if a condition is, you have the luxury of waiting, then certainly, and you're not worried about destabilization, consider a switch in those circumstances. And if the patient certainly prefers this. Augmentation treatment is usually considered in those who have tolerated the medication. You're attempting to build on and leverage further your goals towards further recovery, looking at other measure-based approaches. And there is the concern of severity, and so pulling off a treatment can destabilize them. The consideration of pharmacological treatments can be guided by the following principles. You want to look at what type of symptoms they have, drug interactions, their cost, patient preference, comorbidities, compliancy, response, and tolerability. And I find that these principles tend to serve me quite well when I'm dealing with that complex patient, and I'm really thinking hard about what agent to consider, whether it's a switch or an add-on. Depression is a highly complex condition, and our understanding is certainly growing. But a good practical way to look at depression towards one group of clientele is the whole monoamine understanding. And this is really centered about the role of serotonin, norepinephrine, and dopamine. These three major neurotransmitters govern what we commonly see are the difficulties in feeling, thinking, and doing. Simply put, the 5 out of 9 symptoms of major depressive disorder. We also know that these neurotransmitters tend to interact with each other and tend to lead to a cumulative effect on functional impairment. But serotonin tends to be more associated with more that mood, anxiety, guilt, worthless ideas. Norepinephrine, it's more that energetic, amotivation, decrease in drive, cognitive difficulties, and dopamine tends to be more associated with reward-based symptoms. But again, highlighting that all of these neurotransmitters enmesh at common converging points to address all other symptoms as well. However, when you think of it in that way, it may be relevant to look at certain potential treatments that you might want to consider when you're faced with someone who has primarily more symptom domain-based difficulties, those with cognitive dysfunction, those with sleep disturbances, and those with somatic symptoms. Here's a list of some potential treatments that you might want to consider. The serotonin modulators with their 5-HT1A and 7 properties may be a consideration for someone who's got anxiety and cognitive difficulties more pronounced. Same could be said with certain of the NDRIs, such as bupropion and SSRIs. When you're thinking of more sleep, you want to consider things like the NSAIDs, like mirtazapine, quetiapine, and those with more somatic or pain-related symptoms, SNRIs tend to have a place. Once the determination is made towards considering what agent you wish to switch them to, the next principle would be for how long are you going to keep them? It's important to psychoeducate your patients that once they start feeling better, that's a key time to keep going with the medication, because that's the next phase of treatment, which is the maintenance phase. Acute phase, first 2 to 3 months, maintenance phase, 6 to 9 months. But there are some patients who would certainly benefit with an extended period of time, those for 2 or more years, where we look at risk factors, difficult to treat episodes, etc. Another key message to send here is, when do you wait for the response? There was a very foregoing understanding that you have to wait many, many weeks to see a response. It's not really true now, based upon large studies, from pointed out from the guidelines, and even the very noted Zaghetti study, that early response is something that can inform us of what treatment and response and remission might be like in the upcoming few weeks. So if you can assess your patients 2 to 4 weeks, and you start an intervention and see 20 to 30% improvement in symptoms, it can be a really good predictor of what things will be like, both response, non-response, and non-remission in the next few weeks. With those medication treatments aside, I do always want to point out the importance and the vital benefit that other treatments would also culminate to bring in treatment wellness. We know the interaction between the biological, psychological, and environmental factors. We know and understand the benefits of epigenetics, but here are some other allied professionals and treatments that should be considered to get your patients into full remission. The role of psychotherapy, social-based treatments involving occupational therapy for cognitive training and remodulation, nutrition, and for any behavioral activation or exercise regimens. And so finally, when we think of major depression in its totality, it's a common condition we all are very familiar with. We see the importance of residual symptoms as a key determinant towards functional impairment. poor prognosis, and also poor functional outcomes. So the key is for early identification and treatment and getting your patients fully towards remission through this holistic biopsychosocial approach. Thank you so much.